Hey, good afternoon once again. So today we will talk about the approach to anemia in a child, okay? And for you that has got short-term memory loss, my name is Jan du Plessis, okay? So, when you look at a full blood count, this is just a few general information. Normally we would have started with a case, but I need to today do a few general things first. One must remember the full blood count, when you look at that, it's being done by a machine. Okay, you get automated machines. There's different ones. The ones that we've got at the hospital are Technicon or Coulter machines, and it can give you lots of information. Okay, so and it actually does have a comment about morphology as well. So this is what a full blood count looks like. Okay, so the but was that you need to confirm these results with a hematologist. Okay, so we often use these preliminary results, especially because we need to make a few quick decisions about the patients. So in private, they can give you this within 10-15 minutes, and obviously here much bigger load of full blood count, so it takes about half an hour to 30 minutes, 30 minutes to an hour sometimes to get the results of the patient. But if you look at this, you can get a lot of information. As you can see, there's your white cell count, your red blood cell count, hemoglobin, and then if you go to the bottom, there's your differential count. It gives you the percentage and the actual values that you can look at, so you can get a lot of information. So because we're talking about anemia, so we need to look at the hemoglobin, obviously. Do we ever look at the red blood cell count? You can answer. You've got the microphone. So in what circumstances? We look at the hemoglobin when we look at the red blood cells, don't we?
But if it's I think maybe he's thinking now, it could be now a chronic disease or something.
There is some inherited diseases, remember. So which one will give you small little pale red blood cells, but it still makes a lot of them. So you've got a normal red blood cell count. It's usually Mediterranean families. Thalassemia, okay. So they still make enough, but they just make them small and pale. So they don't have an iron deficiency, but it's because of the thalassemia that gets made. Okay, so they are small. So you need to look at this. And as you can see at the bottom, I think we need the plaster, sorry. This little thing behind my ears falling off. Okay, so if you look at this at the bottom here, there is some comment about the cells that they are microcytic, that they see some of them actually do look hyperchromic to this one. So one needs to have this confirmed by a hematologist, okay, but you can get a lot of information from this. Okay, then when you look at a full blood count, remember this is children, it's not adults, okay, so we know that the hemoglobin values varies with age. So newborns has got a certain value, infants, children and adolescents have got a different values, and there's a difference between males and females, okay? So when you interpret it, look at it according to the child's age, okay? Because the full blood counts, normally the labs just have the adult values. So you've got to have a reference. Go back to your references and look at that, okay, what the values are. Because it's not just the hemoglobin, but it's also the size of the red blood cells that varies with age. The white cell count varies with age as well, until it gets to normal values with age 6 years. And then non-whites tend to have a lower white cell count. So one need to interpret this. And for obvious reasons, why does males have a higher hemoglobin than females? Next lady there at the back, what is your answer?
This is women menstruation.
So if you menstruate, don't you make new blood with your bone marrow? You do. So unless it's an abnormal menstruation and you lose excessive blood, then you will have for a lower hemoglobin, but it's not just because you menstruate. Pardon? Yes. Now what else? What's the other difference? I've heard the word testosterone. Okay, so testosterone. Yesterday we discussed a patient with epistaxis, okay, and we decided in the end that this patient was an aplastic anemia. Okay, so, and I described some clinical features, and we discovered that he is a Fanconi's anemia. How would you treat him? So why? His bone marrow is not functioning. Okay, so how are you going to make it function again? Okay, so that would be first choice. Okay, so that would be bone marrow transplantation is your first choice for that. Okay, but do you think it's easy to find a match? No. Okay, so for state patients, our government pays for a matched sibling. Okay, because there's the most success with them, the least complications with them. Okay, and quite a few years back, 750,000 was more or less the pricing that they gave for a bone marrow transplant. Okay, but now you've got to find a perfect match as well. And then in the private sector, the medical aids will look for local South African donors. Okay, so to get a donor from overseas, you'll have to get private funding. Okay, unless you're lucky in living in a first world country. The unit where I worked at, we got donors from the US, from Britain, New Zealand, all over. Okay, that got matches because we had some interesting dilemmas. The mother, one of the mothers of one of the patients was a coloured from Cape Town living in Australia, married to an Hungarian gentleman, and they had a child together. So now you have to try and find a match for that particular gene pool. Not easy. Okay, so not easy to find a match. Okay, so this young man, yes, he's got a perfect match, but it is his little brother who looks exactly the same as he, and which I diagnosed to have exactly the same disease. How did I prove that they've got the same disease? Do you know what testing you do? And what's the problem with the chromosomes? Okay, an easy way for me to remember, that's how I remember the physical features as well, if you think of Fanconi's anemia. Their chromosomes are fragile. Okay, so they are increased fragility, so they break easily. So the test that you do is called DEB, D-epoxybutane. Okay, is the testing that you do that induces the chromosomes to break. Okay, if you're normal, they've got the ability to recover. Okay, but they don't. Okay, so now the way that I remember the physical clinical symptoms and signs is, think of it, if you have to build a house with broken bricks, is it going to be as tall as that? So no, that's why they've got short stature. The circumference is going to be smaller, so smaller head circumference. How big is the windows going to be? Smaller. That's where the small almond-shaped eyes is coming into. Okay, so some things might actually look a little bit bigger. So the door or the mouth is the puckered shaped mouth, and a puck is what you play hockey with, ice hockey with. Okay, so then there's certain areas, because there's certain lighter areas and darker areas that's going to be, because you use broken areas, so light's going to be let through and other areas not let through, it's going to be thicker. So that's where the skin lesions comes in, because that's what we see. Okay, so the hyper and hypopigmented skin lesions. Okay, and then there might be things that looks abnormal, and if you look at a picture on the anatomy picture of a human being, the thumbs is on the outside. Okay, so the house structurally on the outside there might be problems. So they have some radial abnormalities or just thinner muscle abnormalities, okay? And then some things will be placed in different places because it's all broken up. So you might end up with a toilet in the kitchen and the bath as well in the kitchen and whatever, in the fridge, in the toilet. So you can have things at different places. So that's the ectopic kidneys, and they can have holes in areas, so they can have cardiac abnormalities, and some things might be very small. Okay, so small genitalia. Okay, so that's how I remember these things. One has got to have some interesting ways to remember what. Okay, because if you remember the broken bricks, their chromosomes has got an increased breakability. Okay, because these poor kids, and this has happened with my patient now, his full blood count is actually now demonstrating blasts. Okay, and one should not have blasts on them, so they've got a higher risk of leukemia. Okay, and now if you think of it, yes, he's aplastic, so his bone marrow is not functioning. If I treat him with chemotherapy actually breaks down these cells, so it induces chromosomal breakage, so because it wants the cancer cells to die, and the theory is that they are immature and won't be able to recover, and your normal cells can recover, but in this poor patient, I'm going to kill him if I treat him with chemotherapy. So unfortunately for him, that is not a possibility. Okay, so we don't have. So you have to act actually now supportively. Okay. So you have to try and not give him as many transfusions. Okay, so if he develops an infection because his white cells are low, you will treat that. Okay, but how are we going to get his hemoglobin a little bit higher? And not give him regular transfusions.
Could you maybe do like an alternative transfusion where you,
He's not going to know. So auto transfusion, definitely not. Okay, we just talked about that bottom sentence here. Males have higher hemoglobin levels than females, and that's because of. Okay, so what can I give him? Androgens, hey, okay. So they look like beautiful little athletes, okay. So you should actually see them. They're nice, they're lean, and because this boy that I've had a group of students that we went to look at them as well. And we discussed him, and it's like nobody is seeing everything that, and the other one, it's like she discusses and she says he's got lots of hair on his arms and legs, and he's only 11. And so we're commenting about that, and the one student kept on saying, but he's 11, it shouldn't be there. Okay, so only one clicked that, listen, this hair growth is actually something that I'm doing. Okay, so sometimes what you find on a patient might be iatrogenic, it might be induced by the medication. So we actually do put these kids on androgens to keep their hemoglobins as high as possible, okay, so that they don't. Unfortunately, it is not going to cure him, it's not curative, and eventually you do run out of time, okay, and they do die, but you give them some quality of life, okay, for these patients. So one has got to remember, yes, females do menstruate, and females can develop, if they've got abnormal menstruations, okay, the hemoglobins will be lower and they can have problems because of that, but remember, your bone marrow is still functioning, okay, so that's not the reason why, okay, it is because of the testosterone. That's one got to. Okay, so we've discussed now a whole lot of things as well, and there's lots of different causes, okay. Your approach should be, obviously, we always do, with every patient we talk to them, so we take a history, okay. Then we examine them, then we do a few special investigations, and there might be further investigations, and eventually we come up with a treatment, okay. So, as we saw yesterday, your history could actually give you the answers, okay. So you must use your history and the examination to your advantage, okay, because if you get the history of picker behaviors, what are you going to think of? Pardon? You've got to speak into the thing. Iron deficiency, ne? So one's got to do that. Look at the family ethnicity. Okay, we've already said the Mediterranean family, so think of something like thalassemia. So blood loss, you've got to ask of that. Okay, what medications the patient is using. Menstrual history, you want to know about that. Okay, remember that, because the other day we had a little girl, and then she had, I saw her at the clinic, and she was menstruating and things, and nobody asked her about that, okay, because it's a pediatric clinic and we're not supposed to see them, okay, but you do see them. We do see survivors in our clinics, so use them, look if there's any associated fevers with these patients and signs, so that you can see. On the examination, we all do, yes?
Just a question on the histories. You spoke earlier in the video about restless leg syndrome and iron deficiency anemia. Is there any relationship you can speak about regarding those two things?
A restless leg syndrome.
Restless leg syndrome.
Yeah, who discussed that with you?
We were in gastro, and it was Dr. Simmons. He told us that restless leg syndrome and pica were very early signs of iron deficiency anemia.
Pica, yes. I haven't seen restless leg syndrome, but there might be new articles out of it. Okay, so one can look at that, yeah. Okay. So, okay, but on examination, why are we going to look for jaundice in a patient? What could be the cause for the anemia? Hemolysis. Okay, so the young man that I actually saw on Tuesday, there was a young man that was lemon tingy jaundice. Okay, so it wasn't a dark yellow, it is a lighter yellow jaundice. He was pale, and he had a lovely frontal bossing. He also had his parietal bones were big, and you could see a dent in the middle, and he had probably a 8 centimeter spleen. Okay, so he was lemon tingy jaundice, pale. Okay, that's for you. And what is his diagnosis? Why is his head so big? So the jaundice and the pallor, together with the splenomegaly, yes, it's yours. Let's give him the... No, we've just said. Pallor together with jaundice, you think of hemolysis. Okay. So why is the spleen big?
Because it's going to be big because there's an obstruction in the spleen, which is...
Remember, he's breaking down the red blood cells. Okay, so those abnormal red blood cells, it could be abnormal, they need to go somewhere. The body tries to get rid of them, so the spleen enlarges. Why did I specifically mention his skull bones that is so big? Does he have now rickets?
Perhaps you also mentioned frontal bossing.
It's not soft though. I said the parietal bones are also big. Where do you make blood?
In bone marrow, yes.
Or where do you have bone marrow?
In the large bones, so your femurs, your vertebral columns.
Don't you have in your skull bones? You do. So he's breaking down his blood. What is his body trying to do? Make new ones. Okay. And it's a chronic process. Okay. So you've got to look at the patients, because there's another little girl that I saw at the clinic, exactly the same picture. Lemon tingy jaundice, pallor, lovely big forehead. Okay. If you don't look at it, then you won't remember to put the two together. Okay. So those were the clues. Okay. So those were the clues. You need to go and look at that as well. So obviously on our general examination, if there's lymphadenopathy, what are you going to think of? Generalized lymphadenopathy.
Things like lymphoma or infection, so common infection.
More commonly so, infections. Okay, so generalized. What type of infections?
Possibly managed bases.
Yes, that is in there.
HIV.
Yes, one's got to think of general of all the viral infections. Okay, so one's got to look at that. Okay, so I've told you abdominal, you're going to look for hepatosplenomegaly. Skin, if there's petechia and bleeding, that means there's more than one cell line affected that you need to go and look at. What are you going to look for on the nails? Yes, and that's an indication of? Yeah, it gives you pale nails. What do you get with iron deficiency in the nails? Spoon. Yes, that's how I've got it in it as well, if I translate directly from Afrikaans. So, what do we call that? Okay, you've got it. So, why are we going to look for peripheral neuropathy in a patient with anemia that is pale? Yes, B12 deficiency. Okay, so you can see your examination is going to help you a lot, and you've got to do a whole lot of things. Okay, so sometimes all you can find on your patient is anemia. The patient is pale. So think of all the different causes for pallor. Okay, what could that be? What else do you need to look for to see? Just check the reflexes, check the sensation. Okay, check for petechiae to try and find a cause in these patients as well. Okay, then when you do your special trying to keep up with it. Okay, so you're breaking down the tricks instruction, but also when you're responding to treatment. So a patient could be on iron deficiency anemia, and they can be responding or recovering bone marrow post that. But practically, one's got to think of those are the nice academic ways, but to try and remember it, this is a very practical way that I've found, is that you've got to think in global terms. Okay, so why is this patient anemic? Is he losing it? Okay, is it the female that is just having problems with menstruation? Okay, so, but is there gastrointestinal microphone I've discussed now, the bleeding, that or is then you've got to think of these are red blood cells being made appropriately, but then being broken down. So that's the immunity one. Okay, so it can be autoimmune, can be hypersplenism, if there's a patient with portal hypertension with that as well. And then the first one that we discussed is actually, is the red blood cells not being made. Why is it not being made? It's an iron that they don't have, so there's not enough substrate that will be had. Or is it this transient leukopenia of childhood? Okay, so that when they get the transient shut off of the red blood cells, and they don't have reticulocytes. It lasts about 2 months, but we've got a little bit on this at the end of the lecture. That you've got to think of, is it bone marrow infiltration, or is it actually all the cell lines in the anemia that's been made? Or then, if you look at, is the red blood cells being made, but it's not being made correctly, therefore they are destroyed. So that makes sense, they're regularly stereocytosis. Or is it being made with the wrong hemoglobin, or does it have an enzyme defect? And that's therefore, so the patient that we admitted yesterday from the clinic presented with fever, and he had a painful arm, so it was sickle cell crisis that developed this patient, so that's why he has got a low hemoglobin and that we need to. Okay. Then, similarly, think of the age of the patient as well, and I've summarized for you guys here to think of the certain causes below 12 months. Remember, iron deficiency in kids younger than 12 months is very rare. The typical history is a toddler. Okay, so a 13-month-old where they've changed the milk to cow's milk or something, the kids are not eating very well as well. So there's different causes for each age group. If you look at school age, iron deficiency is still possible, but you need to think of your hereditary stereocytosis, hyperthalassemia, your epileptic uremic syndrome, leukemias, And then obviously later on, again, this is where your females comes in, gastrointestinal loss and leukemia as well. Okay, so now I just want to focus a little bit because you all get asked these questions and these difficult things that we need to see. Iron deficiency, when do we see it? Usually, as I said, the typical history is toddlers or females. Okay, that is losing it. Okay, and they're not with the iron. So the anemia can be quite severe. So it can present in cardiac failure. Okay, where you hear the galoprism with the third heart sound. Okay, and then obviously the reticulocytes will be low, and on the full account, low NCV and the low NCH. Okay, and then you go and test for iron, but you've got to do when you test your ferritin or your iron in the blood. Remember, ferritin is an acute phase 3 agent, so you need to do a CRP together with that. Okay, to check that the patient is not. How do you treat them? Okay. And how long for do you treat them? So you can see there's a lovely little word there in front of the iron. Okay, so there's lots of different iron preparates out there. Okay, so there's ferrous-gluconate, ferrous-roxane, ferrous-sulfate, all sorts. Okay, so you need to go and look, or ask your friendly pharmacist, or actually go and look how much elemental iron is in that specific medication that you're going to use. Okay, so then you give them the appropriate dose. Okay, and the 3 is basically afterwards that you start with 6 milligrams of elemental iron in divided doses. Okay, you follow this patient up 2 to 3 weeks, but a month is probably easier, and do the retics to check why. Okay. Is it working or not? If it's not working, is the patient actually taking his medication or not taking it, or do you have the wrong diagnosis in these patients? Some people say if you've got the typical history, like this typical 13-month-old patient with drinking excessive cow's milk, 2 to 3 liters a day, and not on breast milk typically, you can actually, don't have to do the investigations, you can use your treatment as the trial to see, and as the diagnostic test, treat them with that as well. So one's got to go and look, but if you don't find an obvious cause with the diet or the menstrual history, go and look for a concealed bleeding or a blood loss in these patients. I said I will talk a little bit about hyperglycemia of childhood transient as well. These kids, as you can see, typical age is 1 to 4 years. This is a self-limiting red cell aplasia, okay? And it lasts only for a few weeks. They can have very low hemoglobins, okay? So these patients mild neutropenias, but they have complete bone marrow recovery without treatment needed. Okay. Diamond black family anemia, again, that is, but this is now a progressive neurotropical macrocytic of infancy. Most of them will be diagnosed by age 1, as you can see, so they will be diagnosed at a younger age. And there's up to half of these patients have associated congenital abnormalities, so you should not list them as well. And then these patients don't have high reticulocytes, so they don't produce reticulocytes, and but they can also have an increased erythrocyte ADAs that you need to do. In these patients, how do you treat them? With steroids, blood transfusions, and stem cell transplants might be used. Hereditary serocytosis. I've discussed this patient with you guys again, so this is a very common one, and they've got defective red blood cell skeletal membrane protein that they don't have, and these pseudocytes, they're non-deformable and they're being destroyed by the spleen, so the spleen gets big, increase, and obviously because they break down these red blood cells, your bilirubins increase, okay, with high retics. Why do they get retics? Because they break down the red blood cells. CHC can also increase. So you need to take a family history because it's inherited autosomal dominant as well. Okay? We try and wait until age 5, 6 maybe to do this clinically, and then usually it solves their problems. But once you put them on folic acid replacement, and then I've included hereditary anemia for you guys as well that you can go and read about. Okay, so that is the lecture. Okay, I told you today is going to be a little bit shorter. Okay, that one you do. There's lots of nice, interesting reading. Okay, this should be sufficient for you guys as well. You can go read about your restless leg syndrome. Okay, together with that, but it is probably just one of the rarer causes and symptoms that one's got to have as well. So thank you very much. So sometimes one needs to do a few investigations on these kids. Apparently there's a child with reflux and vomiting and not losing and not gaining weight at the moment in Rose Park Hospital, and they were trying to do all sorts of investigations, and I think the pediatrician got fed up with the mom, but she asked me, please just do a brain scan. Yes, they discovered a brain tumor. So listen to the parents. That's the long and the short. Talk to your patients, listen to them, because sometimes you might actually discover the real cause of the problem. So, but anemia, very common, you need to investigate it very well. Okay, that's all. So now, multiple